All right, welcome back, everybody. My name is Dr. Khan Kao, and today I am joined by Dr. Edward or Eddie Villa. He's going to talk to us about GI or gastroenterology for those who don't know, but we'll do GI for short. So, welcome, Dr. Villa.
Thanks for having me. Appreciate it.
Yeah. First off, to start, just give us your background and a little bit about what you do as a GI physician.
Yeah, sure. So I kind of started things off. So I went to undergrad at Notre Dame, then shifted gears, went to Loyola straight out of college, Loyola University of Chicago, for medical school, stayed on for internal medicine residency at Loyola, then did my GI hepatology fellowship at Cook County Hospital here in Chicago, and then did an additional year of advanced fellowship in interventional endoscopy at University of Chicago. And now for the past year and a half, finally faculty after all that at University of Illinois, Chicago. Long road, but finally got there. Yeah, interventional endoscopy and interventional GI is a little bit different than gastroenterology, but I can talk about both during this just to give everybody an idea, what each one entails. So gastroenterology, whenever you're on service and you have that GI bleeder, you hear, oh, let's consult GI to do a scope. And so that's a lot of what we're known for is endoscopy, colonoscopy, looking for polyps and screening for colorectal cancers. We can remove those polyps at the time of colonoscopy to even prevent cancer. It's one of the only things that we can do to screen and prevent cancers. But GI is really a lot more than that. In fact, most practices in GI, it's not just procedures, it's mostly outpatient clinical medicine, a lot of inpatient medicine on consultation, a big smattering of chronic abdominal pain, which comprises the majority of the outpatient follow-ups. Irritable bowel syndrome, constipation, diarrhea, or mixed is the number one diagnosis encountered in GI clinics. But everything from gastroparesis, GERD or Barrett's, esophageal dysphagia, gastritis, intestinal disorders, all the way to near surgical things like removing big polyps from the colon, dealing with stones in the common bile duct, choledocholitis, pancreatitis. And then, of course, when you go into interventional GI, there's a lot of other procedures that we do that are pretty novel and rapidly evolving.
Awesome. Thank you for that broad scope of GI. Thinking back to your med school days, did you felt like GI was the path? Most people know or may not know that you have to go through internal medicine first,
Right.
and then subspecialize. But was GI always under your radar, or what other things were you considering?
To be completely honest, I was trying to avoid GI as much as possible. It's actually really funny. So I'm third generation GI. My grandfather came from Cuba, and his team in Cuba developed the abdominal laparoscopy and brought that to the United States, trying to get the GI doctors to adopt it. But the GIs were just like, oh, this is never going to catch on. And the surgeons were like, oh yeah, come on, bring it. So he taught a lot of surgeons here in Chicago and all over the country how to do laparoscopy. And then my dad ended up going into GI because, back in those days, you could bring your kids to do everything that you did. Growing up, my parents, to a certain degree, discouraged me going into medicine. And so I was actually planning on being an engineer. And I saw my dad one day, he needed a ride to the hospitals. And so I saw him do some procedures on a Saturday between my junior and senior year of high school. And I thought, wow, this is awesome. This is like playing a video game. But I didn't want to be that cliched, my whole family's done this, so I should do this sort of thing. So I ended up applying as an engineer into undergrad, and the math and physics side of things I absolutely loved. So I almost didn't even go into medical school, but started volunteering at hospitals and things, and realized that I wanted to do med school. And so when I got to medical school, the last thing I wanted to do was be a GI doctor. So I, during anatomy, for some reason, GI just seemed to click. Physio, path, it just seemed to click. And so I'm like, this sucks, I'm going to be a GI doctor. So I tried to love OB-GYN, love pediatrics, and I loved both, but not enough to really go into them 100%. Internal medicine, ironically, I was not as big of a fan of. 4 hours of rounding a day was kind of painful to me. And so I thought, well, maybe I'm destined for the operating room. And so I absolutely hated waking up at 4:00 in the morning to start in the OR super early. And then then everybody told me, well, if you like the OR, but don't like, the surgical life per se, then do anesthesia. So I did an anesthesia rotation, and pharmacology was never my strong suit. So it's kind of one of those things where, well, what do I do? So it wasn't that medicine was a fallback, but it just kind of had the blend of opportunities to be able to branch out into a variety of different specialties. And I would kind of see with my residency training what direction my interests would take me. And what was nice about internal medicine residencies, you really get the whole gamut, cardiology, pulmonology, GI, rheumatology, the whole thing. And so you really kind of see what are some areas that excite you, what are some things about each specialty that you like or don't like, and go into that. And I thought with internal medicine, it was kind of a good avenue to kind of investigate and explore, at least more in the post medical school side of things, what particular specialty would really interest me, with a little bit more emphasis on those specialties than I would have otherwise gotten during medical school. And then, GI, with the combination of, the procedures as well as clinical medicine, and the opportunity to go into a field like interventional endoscopy, which is very, very procedure heavy,
Mhm.
near surgical, I would say, kind of really appealed to me. And that's kind of why I went the path that I did. But yeah, it's 3 years of internal medicine residency, then 3 years of GI hepatology fellowship, and then to do interventional GI, it's an additional year or two, depending on where you go. In my case, it was just an additional year.
Awesome, awesome. Very long, winding paths, like most of the subspecialists. And I appreciate your thought process and telling us, mean, how you came up to wanting to do GI, even though you try to avoid it at all costs. It seemed like so. Appreciate it. What personal quality you think are fantastic to be successful in GI?
I mean, in general, I think any sort of personality would really work. I'm very impressed to find that, the fellows that I've been able to work with, both during my fellowship and afterwards as an attending, or even rotate under as a resident or medical student, how varied they really were in terms of their personalities. You know, um, I think in general, you kind of think of GI doctors as being very well adaptable. They can react to a lot of different situations. When you're on call, let's say in the middle of the night, you may get a call at any hour to come in and do an endoscopy on somebody that's bleeding, for instance. And so having that ability to kind of react on the spot, and be able to make some quick decisions, even when you may not have the right frame of mind to really think 100%, if you're tired and just waking up, sort of thing. I feel like, but I feel like a lot of people have that skill going into medical school already. You all already have those skills, all the all-nighters you pull, all the different subjects that you're studying all at the exact same time. You're all very adaptable, all very resilient. And those are big, important qualities to have, I feel, in almost every specialty, if not all of them. One thing that I've found that's very interesting is there are multiple studies that have shown people who are good at video games, or play video games, or play musical instruments, especially musical instruments that involve their fingers, tend to do very well in endoscopy. And so those are some traits, to think about. Hey, if you have a personal hobby and you like those sorts of things, translating those skills into the procedural based specialties actually is pretty good. And even if you don't have that background, the amount of exposure and experience that you'll get during the training, you'll usually result in being a decent endoscopist, if not a good one. Um, People who like variety in their days. So as I kind of alluded to before,
Mhm.
a lot of GI is outpatient medicine, but we do procedures at the same time. And we also do inpatient medicine where we're on consultation. And so there's emergency cases and things as well. So it's a nice field where you can kind of get multiple different slices of the medicine pie, where you're kind
Yeah.
of in different worlds at the same time, which it's nice to kind of spice up your day that way, not just do the same thing every single day. I think those are kind of some good personality traits to have.
Awesome. Thank you for that. And you touched upon the variety. Is that the most specific thing that you like most about GI, or were there other things that you like the most about GI?
I mean, that was one of the big appeals for me, when, going through my medicine residency. I feel like, maybe pulm crit and cardiology, um, uh, are kind of similar in that regard, where you have a multifaceted kind of approach to practice, and you have multiple different little offshoots to be able to go into in those subspecialties as well. What I loved about GI was everybody, no matter who you are, has hands on. So you're very hard pressed to find a gastroenterologist that does not do endoscopy or colonoscopy at minimum.
Mhm.
So you're getting that procedural side of things, and that's very gratifying, because if you have something, let's say you're dealing with a bleeder, I know I keep mentioning that, but this guy's pumping out, they're becoming hypotensive in the ICU. You don't really want to call interventional radiology, or they're taking a long time to come in. So you go in and do a scope, and you can stop that bleeding, and then the patient does well, their hemoglobin stabilized, and they get to go home. That's super rewarding to be able to take care of something like that. In my particular field, I deal with a lot of GI oncology as well. So advanced polyps, so very large polyps that in the past we would have to refer to surgery to remove.
Mm.
We can remove those endoscopically now, and even early cancers we can remove. So being able to do something like that and telling somebody, hey, we had a very advanced polyp here that was going to turn into cancer, now it's gone, you're fine. Or hey, this ended up being an early cancer, we've completely taken it out, you're cured of your cancer. Being able to tell people something like that and do things like that is pretty awesome. So I think that was kind of one thing that really that I absolutely love about this field. But the variety is key. You'll find, especially during training, when you're doing the same thing over and over again, things that kind of stale and boring. But having a little bit of a change here and there, especially if it's every single day, you're doing multiple things, it keeps you on your toes and keeps you engaged and interested.
Awesome. Oh, cool. On the other end of the spectrum, what do you dislike about GI? Or if you can think of one or two things that you would just change regarding the specialty?
I mean, the amount of time it takes to get here, I think in general, I go back and forth on this because it's super important out of the medicine specialties to have that internal medicine training. To be a good GI doctor, you also have to be a good internist. At least that's what I think.
Mhm.
My internal medicine skills, with all the training that I've gone through, has kind of gone down the wayside. So I have tremendous amounts of respect for IM hospitalist, outpatient IM folks that are taking care of people, because you'll be surprised how quickly you forget things. But in order to get to GI, there's so much overlap with the GI system with every other system, really. And I would argue more so than any other system within the purview of internal medicine, that you really do need to kind of know a lot of it. So I kind of go back and forth on you know the amount of training that you need to get there. And there's a lot of debate now whether or not to change the GI fellowship, because it used to be a 2-year fellowship. And now we're seeing a lot more and more people further subspecialize out of GI. Most people go into general GI, but people like me going into interventional GI, some
Mhm.
people specializing in motility disorders, some people going into the inflammatory bowel disease, some people going into transplant hepatology or general hepatology. Um, so some people are arguing that we may need to change it to a 2-year fellowship, followed by expanding the advanced fellowships afterwards. So that's, I think, one area where I think is valid. I think most people can get a good amount of training within 2 years in general GI, get a good number of procedures in under your belt, and then can use an additional year to further hone whatever they want to do, whether it's stay in general GI or go into one of the offshoots. So that's one thing that I would change about the specialty, and one thing, not necessarily that I don't like, but I think that probably needs to be adjusted. Um, the other thing that I would probably change is our in general communication with primary doctors and generalists, because there's a lot of overlap with other diseases and things, that I feel like having a better multidisciplinary approach to our education, and potentially streamlining how we assess our patients. Again, the most common reason people come to GI clinic is for chronic abdominal pain.
Yeah.
And a lot of times, for us, the outpatient internists that are referring those patients will say, well, this is GERD. Well, I'd say maybe 5% of the time it's GERD. So, people are being told it's a diagnosis, and then they come to us and they're completely shell shocked. Oh, this isn't GERD. So what is it? And people aren't really satisfied with irritable bowel syndrome because they think it's a made up disorder. So I think with further education of our general colleagues, we can further educate our patients together, and really arrive at an endpoint where the patient is better educated, more accepting and embracing of their diagnosis, leads to improved efficiency and delivery of care. But I think right now GI is kind of tries to stay a little separate from the generalists to a certain degree, and I feel like there's a lost opportunity there for widespread education.
Okay, awesome. Thank you for that. And I can totally understand from the physician standpoint of chronic abdominal pain and telling them, I have no clue what you have. We
Right,
did, you know what I mean?
right,
We did everything in the ER that we can capable of, but
sure,
from that point, but you'll need to follow up with GI and they get
right,
frustrated with that. So,
right.
but yeah. So it sounds like, you know what I mean? It almost seems like, you know how there's surgical subspecialties that have gone their own path, like plastic surgery. Do you feel like GI could, go down that route where it's like an integrative path for GI versus 3 years of internal medicine?
I mean, I think so, to be completely honest with you. I think, especially when it comes to interventional endoscopy, for instance, I think, our knowledge of the medicine, really, if you kind of boil it down, you know, with Barrett's therapy, so Barrett's esophagus, we do ablation therapies. We burn or we freeze. Sometimes they resect Barrett's if it's advanced. Um, all you need to really know about is GERD, for instance. And, with pancreatic biliary diseases like I take care of,
Hmm.
we co-manage acute pancreatitis, but everybody knows to give lactated ringers and a ton of fluid, NPO, and then try to advance their diet as soon as they can, sort of thing. And stones in the bile duct, we do an ERCP where we go into the bile duct and we open it up and try to remove those stones, and then they ultimately need surgery. So when it comes to interventional GI, we are more of a surgical field than we are a medical or clinical field, to be honest with you, or at least it's evolving that way with a lot of that we're doing. Um, so a lot of people have argued that it should be its own specialty. GI coming out of medicine, like I said before, I flip flop on this. I do think that it is important to do medicine residency first, or if you know you're going to be going into GI, maybe doing 2 years of internal medicine and then going into GI, sort of thing. Or, but that would require a big systemic shift in how we undergo our training, especially in the internal medicine side of things. Um, but I see GI becoming very, very surgical in the future. The way that it's really expanded now, I mean, I'm doing cases now where somebody has cholecystitis coming in, and normally for cholecystitis they go for surgery to get their gallbladder removed, the cholecystectomy, right? But some patients are too sick to go to the operating room, or the surgeons say this patient will never be well enough to go to the operating room. They'll die on my table. So then they end up going to interventional radiology, getting some tubes stuck in through their skin to drain their gallbladder. And then they get all these complications related to that drain through the skin. And plus patients hate it. Interventional endoscopy with endoscopic ultrasound, we can take a scope, go down the back of the throat, look at the gallbladder, put in a permanent tube that drains the gallbladder into the stomach or into the intestine, and they never have to go for surgery. And it takes 20 minutes. So, obstructive cancers from the pancreas, if they get blockage of their duodenum and they can't eat, we can, with endoscopic ultrasound, connect the jejunum
Hmm.
and the stomach together and create a bypass that doesn't need surgeries input. So we're doing so much now that we weren't able to before endoscopically, that I feel that especially interventional endoscopy is way more surgical. And I think in and of itself, at one point, may end up being one of those things where people just go straight in,
No.
or we create a pathway to do GI, an abbreviated GI fellowship, to go straight into interventional endoscopy. Um, some of the other fields like inflammatory bowel disease, I still think will require a general medicine and general GI sort of training. The only exception I really think is interventional endoscopy with regard to all of that.
Okay, awesome. Thank you for that. So you briefly discussed about calls and things like that. How has GI shaped your work-life balance in general with other GI colleagues, and if you can also discuss regarding working private versus academic institutions.
So I can say in general, the quality of life definitely shifts from the time that you're in training to the time that you're in attending, no matter what part of GI you really go into. And there's a wide spectrum of your work obligations, duty hours, full-time employment, time off, and everything in between when it comes to call. It really does vary depending on the setting and depending on the group that you're in. So kind of with GI, being, having to take call, most GI doctors are going to take some kind of call. General GI or even inflammatory bowel disease specialists will usually float into the general GI pool. So depending on your group really determines how often that you're on call. In private groups, especially if you're a smaller group, you're going to be on call more often. My father, he's a member of 3 GIs at their hospital, so he takes call every one week out of every 3. Whereas here at UIC, for interventional endoscopy, because there aren't too many interventional endoscopists, I take call 5 months out of the year. So it's a wide range. In general, though, you're splitting it up with whoever you're working with. In terms of the day life balance, most people tend to favor the outpatient clinic-based model. So it's usually 3.5 days of clinic for most private practices. And then, of course, the way that practices really do make their money is doing procedures. So you'll see, 2, maybe 1.5 to 2 days of procedures or scope time, maybe even more, depending on the practice model. A lot of GI groups these days are able to expand enough, especially the big groups, where they can afford their own ambulatory surgical centers, where they basically have a building where they can go and do their procedures in. That's in conjunction with their clinic. So if you are in a practice that has its own ASC, ambulatory surgical clinic, you have more opportunity to do procedures, and they typically churn out a lot of procedures during the day to make that money for the practice. But those are very busy. But unless you're on call, what's nice about it is most of the time that you're home, you're home. You get to live your life, and it's a good quality of life. In fact, Medscape and a couple of other medical bodies have actually looked at quality of life and physician satisfaction among specialties. And GI, I think, ranks number 4 in terms of income, and number 4 or 5, depending on the year look at, in terms of job satisfaction. So GI doctors, while you're busy during your working hours, you love life and you get to enjoy it. And I think part of it is because of the variability, the variety within your scope of practice. And on top of it, once you're home if you're not on call.
Awesome. Thank you for that. So how has GI changed over the years briefly, and then with COVID-19, I think we're all affected by it. And then if you can discuss what you think the future of GI would be like.
Sure. Yeah, so I think from where it was even 15 years ago till now, you're starting to see that the compartmentalization of GI, inflammatory bowel disease, motility, general functional bowel disorders, interventional GI, hepatology, especially in academic centers. In private practice, you're going to see everything. But I think a lot of general GIs nowadays, if it's something that's kind of niche, they'll refer to an academic center. So I think that's changed significantly over the years in terms of what we're able to provide for patients. We're seeing a lot more referrals on the academic side because, we're about 10 to 15 years ahead of outpatient community-based GI. How it's changed during COVID. So at least here, and I know in most institutions across the country and even worldwide, we were starting to see people cut back on elective cases. So things like screening colonoscopies to look for polyps and to look for cancers. We still kept the urgent and emergent procedures. So if anybody's in the hospital with a bleed, we didn't say, oh, they got COVID, stay away. No, we would still do those procedures, obviously with increased precautions, but to kind of balance the patient safety, the public health considerations that have to be taken with patients with COVID to not spread the infections or to staff or to other patients. You saw a reduction in the volume of cases and increased time in between cases. It has delayed things rather significantly because every patient that comes in needs a COVID test, whether it's done within, depending on your institution, 48 to 96 hours before the procedure or the morning of, you're still waiting for that test to be done. And if it's positive and it's an elective case, we're still seeing ourselves pushing those cases until we can retest them based on CDC guidelines. I foresee that when everything kind of gets back to normal, we're going to expand back to our full capacity and even having to catch up on things as well. So we're going to be pretty busy on the GI side of things. Production-based reimbursement models those sorts of physicians, we're going to see an uptick in their productivity, which is going to be good for them. where I see it kind of going in the future is I see it further compartmentalizing. There's already talks because with interventional endoscopy, we don't have our own board exam. So we still have to take the general GI board exam,
Mhm.
which has everything, GI, liver. The transplant hepatologists, they have their own board exam for more advanced liver disease and things like that. And so there's a lot of talks in terms of further separating within GI, how to go about recertification, retraining, and that sort of thing. But I only see it expanding and expanding, especially interventional endoscopy, with our technology expansion and the innovation within the field worldwide. We're just doing so much more, and truthfully, taking a lot of job away from the surgeons. So I feel like that's going to be a big thing where GI is going to now be called on to do things that the surgeons in the past were called on to do.
Awesome. Awesome. And then, are there any myths regarding GI that you think are unfair or untrue?
That's a great question. So I remember when I was a resident, I would always think that, well, I was always trying to get into GI, so I didn't want to shovel this off, but at least some of my co-residents, whenever you'd have a person in the emergency department, you go evaluate to do the H&P on, everybody will always say, oh, I'm not going to do the rectal exam. I'll let GI do it. GI doctors don't like doing rectal exams, to be completely honest with you. We absolutely hate guaiac testing. Absolutely hate it. If you tell a GI doctor, oh yeah, I did a guaiac in the emergency department, we will hopefully be calm on the phone. But in our mind, we'll be like, wow, who is this nut doing something that's only meant for colorectal cancer screening in average risk patients in the outpatient setting? So one of the biggest pet peeves of GI doctors is a guaiac test in the emergency department or anywhere in the hospital, especially testing it on vomit. We love that. Oh, doctor, the vomit came back positive for the guaiac. It's like, oh, okay, all right. So those are kind of the little things. But in general, I think I don't feel like we're the surgeons of medicine. Some people say that we're the surgeons of medicine. I think we're going to get there one day. Interventional GI, you're going to see a lot of people with egos, depending on where you are. But in general, I feel like GI doctors are really chill. And I think part of it is because they're just, in general, happy with how life is going. And we're always looking to help out in any way that we can. I, for one, am not the smartest individual, the smartest doctor, but I do like to take the time to educate house staff on a variety of things, not just that in an academic setting, but because I think the more that everybody knows, the better we can serve our patients. So I feel like a lot of GI doctors will hopefully develop that in between their scope times and their clinic time. But in general, we're very, very approachable.
Awesome. Awesome. And then, do you work with mid-levels such as NPs and PAs? And how do you think or see their roles changing, if any, in the future?
I've seen it change dramatically from the time I was a medical student until now that I'm in as an attending. And I've had the benefit of working now at 4 different academic hospitals here in Chicago. And I've seen the role of the nurse practitioners and the PA expand. And I think a lot of that is there's just so many referrals to GI because everybody has abdominal pain. And so everybody with abdominal pain will get referred to a GI clinic to evaluate that abdominal pain. There's just not enough hours in the day to see everybody. Here at USC, we're backlogged over 5,000 patients in our clinic for referrals. It's insane. So, all hands on deck is very important. And what's nice about NPs and PAs, you can really train them, especially in the specialties, to know what questions to ask, what considerations to make,
Mm-hmm.
who should get an endoscopy and maybe who shouldn't. And that all comes with experience, training, reading the articles and all that stuff. And that's why I think with a mid-level, the role really, really does help. There was a rumor, not a rumor, but there was a whispers of a movement to train nurse practitioners and physicians assistants to help out with endoscopies, meaning that they would be the primary proceduralists. But I think GI physicians in general put a kibosh to that pretty quickly. We don't think that it's ready for prime time there yet. Not that they wouldn't be able to handle it. Trust me, I think if I can learn how to scope, anybody can learn how to scope, truthfully.
Mm-hmm.
But I just think right now, I think GI doctors have such a stronghold, at least on the procedural side of things, that I don't see that changing anytime soon. I think maybe one day it could. Conversely, back in the day, you'd have a lot of primary doctors be able to do things like flexible sigmoidoscopy in the clinic. Now you're not seeing that as much. It's actually very rare to find a general doc that knows how to scope. So I think GI has kind of really kind of monopolized that, so to speak. But I do see that changing potentially in a couple decades when we just realize we just don't have enough doctors to do every single procedure. I think at some point that's going to change.
Okay, awesome. And GI is a very competitive field. And so, how do you see the job market in 5 to 10 years when the current students are coming out wanting to do GI?
Everybody needs a GI doctor. Everybody, now that the guideline says 45 for screening colonoscopy,
Mhm.
everybody's going to need a colonoscopy for the most part. There's going to be a growing need for GI, and frankly, we don't have enough fellowships to churn out and replace the doctors that we're losing. So I think in general, there's a pretty good job market out there. Most hospitals are, with expansion of medical systems, they have multiple GIs on staff, not just for quality of life, but because realistically, GI is a moneymaker for hospitals. Our procedures generate revenue. And so now that we see a lot more administrators involved in medical care and in running hospitals, GI is a very popular and a very, frankly, very sexy subspecialty. So um, while the number of fellowship positions has not really expanded much, the desire, the demand for GI doctors only continues to grow. During the pandemic, we were starting to see a lot of hiring freezes as a result, of course, of lost hospital revenue and income. But now that I think that we're starting to expand GI pretty much universally, I think, the hiring is back on. And I definitely foresee that this is a specialty that has longevity and has a lot of availability for people going in. You're going to find a job out of fellowship.
Okay, awesome. And are there any additional resource for students to um, find out if GI is a good fit for them or just more in general GI?
Mhm. So there's a very good society that we have in here in the United States called the American Society of Gastrointestinal Endoscopy, ASGE.
Okay.
The ASGE is absolutely phenomenal. It's a GI society that also focuses a lot on the procedural aspect of GI. So they have videos to look at cases, look at how people do these things, what are the novel things that people around the world are really contributing to the growth of the field. That's something that I always tell my students, hey, when you're curious, just pop a video on, see somebody take out a large polyp, see how cool the stuff that we actually do is. And really the best resource is your GI doctors at your institution, wherever you're training. There's always some connection. And you're very hard pressed to find a GI doctor that is not going to take on a medical student, especially. We love it when people come into our room. We love it when people walk around with us and learn from us. It's actually a lot of fun, especially for me. So I think going to your GI doc and just saying, hey, listen, I don't know what I want to do in life, or maybe I am interested in GI. Can I shadow you? Almost always. I've never had a situation where I've seen anybody get turned down.
Awesome. Thank you for that. And lastly, do you have any top tips that you want to give to students who are interested in GI?
Patience. Honestly, I think one of the hardest things about getting into GI, it's so competitive for a lot of different reasons. With a less than 50% match rate into fellowship. Previously, one of the big things that would be looked at was your step score, but now I think we're doing away with looking at the step as a guide for how good a candidate is. The number one thing that people look at, and I know this because I'm on some of the admissions committees for the fellowships, um, who is writing your recommendation letter and what you've done within the field. So even if you're not the first author on a world changing manuscript, being an author involved on a paper, even a poster presentation, or even a local research presentation within your medical school or even during residency goes a long way. It shows interest, it shows dedication, it shows you want to start something and take it to completion, which is a big thing. So letters, research are two big things to get your foot in the door with GI.
Oh,
Mentorship is huge. Like I said, most GI doctors love it when people come to them. And if you're genuinely interested in GI, the thing that helped me especially the most, because I'll be honest, I did not do very well on my step on my step one at all. Most programs that I would have applied to would have turned me down, if not for the fact that I had developed a relationship with some of the people within my GI department, GI division during my residency in medical school, and they vouched for me. And so, if you have that sort of mentorship, and you will find that wherever you are, you'll find a mentor. Relying on your mentor, not being shy about it, because they ultimately, if they like you, they want you to succeed. And so telling them, hey, listen, I need some help getting in. You know anybody I can talk to? There's tremendous resources. The GI community, believe it or not, is relatively small. So a lot of people know a lot of people. So, and networking is a lot. So I think those are kind of big tips to get into GI. But a lot of it, of course, is patience, perseverance, and hard work. Uh, but you guys have gotten this far already. So you guys have all the tools in your arsenal already to succeed.
Yeah, I appreciate that knowledge drop. I think meeting mentors has dramatically improved a lot of people's lives and success that I think are quite undervalued in some cases, and you don't realize it how much of an impact it actually has. So I appreciate that process that you brought out. All right. So that's all the questions I have. I know you're a super busy guy. You're still at work and whatnot. So I appreciate you taking your time, Dr. Villa, on doing all these questions.
It's my absolute pleasure. Thanks so much for having me. Really appreciate it. And if, you know, I can give you my email to, if anybody has questions, they can always reach out to me. I have no problem.
Awesome. Awesome. Thank you for that. And lastly, anything else you'd like to add before I turn this thing off?
Keep being amazing human beings. You guys are awesome. You guys are the heroes. Me doing what I do, I couldn't do it without having the motivation from people like y'all. You guys are incredible. Just remember to stay strong, keep resilient. Whatever the future holds, it'll come to you with hard work. You guys will do great.
All right. All right. Thanks, man.